So as you saw from the title of our flyer, we're here to talk about messages from the front lines of folks who are on the absolute front lines of the fentanyl crisis in our area. And several things came up in discussions with them at various points in the last few months that just seemed like it would be very relevant to have it together all in one place for those of us who treat people who are struggling with opioid use disorders in this fentanyl era and people who are trying to do research, or both. So I'll do a brief introductions. Some of you saw this on the email message. And then we'll sort of start with an informal discussion going through the topics that we listed on the flyer and any others that come up. So we're not really restricted to those topics, but those were things that actually arose when we had talked informally in the last few weeks. So our panelist, Joan LaJoie, is a CRNP with extensive experience in addiction treatment, managing care teams at the Philadelphia Health Management Corporation, PHMC, the care clinic at 1200 Cal Hill Street. She also works with HUP, and I believe that experience, Joan, is with the cardiac teams in internal medicine.
Yes, heart failure.
And we have, or we soon will have, Mary Kramer, who is a Center of Excellence case manager serving individuals with opioid use disorder at the PHMC Care Clinic, also at 1200 Cal Hill. And she regularly shares her journey of recovery and hope to the broader community, and recently completed her degree in social services at Lincoln University. Congratulations.
Under there,
Region.
there's nothing.
Well, Mary, I think Mary might be coming on.
Oh,
At least her name is very big on my screen right now. I think that's a good sign.
I look at nothing.
Mary, can you hear us?
Well, I'm sure there is. Sure there is. Okay.
I can hear someone.
No,
A
bigger
big
pot.
part.
The biggest pot I see is very
Not big
big.
enough.
No.
Show me which one is it?
We're getting a little bit of feedback though, so it could be that
The bigger one. The bigger one somewhere, either on the bottom or inside the head.
Nothing.
Bottom.
for anybody who's not speaking, you might mute yourself, except for Mary, because we're trying to get her connected. All right. And then we have Daryl Flynn, MHS, who's a program manager at the consortium at 451 University Avenue, providing a full range of addiction and mental health services to the members of the consortium. He also does extensive outreach, going to community hotspots. He and Kalel sometimes go together to engage individuals in treatment and recovery. And Kalel Duncan is an intake care manager and certified peer specialist at the consortium at the same location, 451 University Avenue. Very passionate about his work and helping others to recover, and works in community outreach and is pursuing a degree in social work. So let's see if we have Mary before we actually stop studying on some of the early topics. Almost afraid to ask. Mary, can you hear us? I can't hear anything from Mary yet. Any more ideas? That was a good one for the chat, and Joan, good idea to call her.
I'm calling her again.
Okay. And she might even be on her email for anyone that has her email. And then what I'll do is, we'll basically be able to include Mary in the conversation, because each one of these topics will be sort of brought up informally and people can comment in whatever order feels comfortable. And basically, if they have more to say or less to say, that's fine. And we also encourage people from the audience. So the topics, though they don't have to be in a special order, we could start with the outline, and I'm going to try to do screen share if that doesn't throw everything out of kilter. Let's see if it does. And go to the few little slides that are just sort of our outline. Let's see if we can see PowerPoints or not. So anybody seeing that yet, or do I have to grab screen share? I'm not seeing it yet, but I should. Desktop 1. Okay. These should look like here we go, like a PowerPoint. Okay, let's see how this works. Can you see those now?
Yes, we can.
Oh,
Yeah.
great.
Yes.
And let me put those in a full screen format. And let me go to the first one rather than the last one. Okay, so the first one here is just, you'll recognize it as our flyer, where we have pictures of our panelists. And one of the first topics was basically, that came to my mind, was just the challenge of obviously the fentanyl overdose rates and the fentanyl overdose reversal. So I thought for an opener for this, that it might be a useful reminder that we're all sort of painfully aware of it, of the rates that were already really high, even before the pandemic, right? With fentanyl sort of pushing that curve of opioid overdose in our area, looking like a rocket taking off. Here, this red arrow on the upper left, the kind of rates that made Philadelphia one of the very top cities in terms of the rates. And this was bad even before COVID. And with COVID-19, this is only worsened. And so I thought that one of our starting points might be to talk about these overdose rates, those of you who are living on the front lines, and to talk about how fentanyl has impacted this in your experience. So it can be anybody, and I can stop sharing so we can see faces. And if not, we can go by person, but Joan, Kalel, Daryl, please chime in. And of course, people from the audience as well, and maybe even Mary. So when this pandemic sort of hit us in the last almost now 3 years, 2.5 going on 3, what were the things that you began to see in terms of overdose rates and the difficulty in reversing overdose that comes along with fentanyl? Some experiences with that, or things that patients have told you about it.
One thing I can say is, since I'm working in a clinic,
Mm-hmm.
and I don't really have that much experience with fentanyl overdose in real time, when people are
Right,
overdosing,
Mhm.
because by the time I see them, we're starting treatment and everything, but I know that there has been a lot more overdoses because of fentanyl. And COVID-19 has not been it's been hard on the opioid crisis and everything on everybody. And I know people had a lot more stressors and they were using more, and it still kind of even up to this day, like when I have patients that relapse and when I hear when they're buying on the street and I'm talking to them about fentanyl, I don't know, maybe they're selling me a bill of goods or something, but a lot of people are still kind of surprised that what they could be buying and who they are buying from might have fentanyl in it. And I don't know if there's a lot of mistrust with whom they're buying from or what, but I know that there have been a lot more overdoses, and I do know that they tell me that they're harder to treat.
Mm-hmm.
And I don't know, is there a lack of information out there on the street about fentanyl and overdosing?
Yeah,
Go ahead, Daryl. What's your experience with that? And Kalel.
one thing I want to comment on is exactly what Joan was saying, was that we don't see it here. We have yet to experience someone actually overdose on fentanyl at the clinic, but we have seen a rise of our members die of actual fentanyl use. One of the things too I want to speak on is that now what we're seeing now is that there's a lot of overdose due to fake fentanyl pills, Percocet pills, fentanyl. That's something that is really, really starting to become kind of like common. I hate to say common, but that's starting to really be an issue. Particularly, I would say South Philadelphia, West Philadelphia area. where the use is more of a pill opiate use than a actual injection type of use. But we definitely have seen an increase of members on our clinic dying from fentanyl use since the pandemic.
Absolutely. Yeah.
One of the things that I think definitely is a correlation is that kind of like the fentanyl epidemic and the actual pandemic kind of like went together. So it was like the perfect storm. So, normally members would come into our clinic, have in-person treatment, real face-to-face type of therapy. And all of a sudden we were thrown into the use of telehealth. And telehealth, in my professional observation over the course of the pandemic and its use, is effective with a certain population, but it's not effective with another population. And definitely it has some challenges in regards to people that are quote unquote intensive level of care type of people that come. So.
I think that's important. And that's actually one of the comments that stimulate one of the topics on our list here, which is basically what has been the impact of the pandemic. And one of the impacts is obviously a shift to telehealth, which serves some people, but may not serve everybody, including people who are already suffering a lot because they have disadvantages. They may not have as much support. They may be already isolated. And now they're actually, ironically, going to lose some of that in-person face-to-face support that may have been one of the components of their recovery.
Yeah,
So
I agree with that. And Daryl, I agree with you too about the pills. And from what my recovery specialists tell me, they're called press pills, and they look exactly like Percocets that you would buy on the street or anything. And that's what I get concerned when my patients act like it seem like they are unaware of this, of press pills, because a lot of my patients that have relapsed, I think that's what they relapsed on. And I also agree with you about telehealth, and I do think it works in some populations. I'm kind of from the school of thought that everybody needs to be treated individually, and I have some people that I think have done well on telehealth, and where others have not.
Khalil, you were going to say something? Yeah.
Yes, I was going to speak to the fentanyl and the overdosing and the spiking rates. It has a lot to do with also as the fentanyl, the prices are cheaper now, so they can use more because it's cheaper. And then it's not just because of the fentanyl, it's the combination of mixtures of substances that's also causing
in terms of
a higher rate of overdosing.
The spike in overdose rates, right? Because you're saying it's cheap. And then we've talked about the fact that people were perhaps obviously having stress, adversity, the things that go on in the pandemic, and the isolation that might have kept them apart from their program, which sort of links into what we were just talking about, which is how do we get people to stay linked into their program? Joan, go ahead.
Mary's here.
Oh, great. Welcome, Mary. We were hoping we would be able to get you in this situation here. Great. We did introduce you already, and even if you didn't hear it, it's what I had sketched out or written down. So you have been introduced, and we're just starting in on some of our topics in an informal way. And first, we're just talking a little bit about the spike in overdose rates that we saw in the pandemic, and what's going on with that, and how are we seeing that manifested? Where are we seeing it? And then how some of the best plans to give people health care in the pandemic, which sometimes took the form of telehealth, may not have affected everybody equally positively. And so we were just getting on that topic for a moment. So Joan, Khalil, Daryl, do you want to continue on that? Mary, do you want to comment on any of that piece about the impact, perhaps unintended, of telehealth for some of our populations?
No, I just want to comment too that we're starting to see fentanyl in urine screens of people that use marijuana. So the fentanyl is in and I personally lost my brother in 2019. He was using cocaine laced with fentanyl. So what we're seeing now is that fentanyl is in everything. We have people that come in that coming in for cocaine, use disorders, and we take the urines, it's fentanyl in it. So it's really, really, really a crisis. But it's just, I just want to emphasize that it's just not the opiate user that are being fentanyl, it's everyone now.
It's so very true. And basically, I mean, when you look at the sad statistics from the Philadelphia Medical Examiner's Office, overdose deaths that are attributed to stimulants, most of the time fentanyl is also present. And so those two things are really overlapping heavily right now. So someone who thinks they're just using cocaine and thinks that they may be using recreationally cocaine may get an unintended dose of fentanyl that actually turns out to be absolutely life-threatening for them. Mary, you haven't had a chance to say much yet because you were getting connected up. What would do you have any thoughts? Do you have any thoughts on this one?
Yes, so some of the unintended consequences of telehealth that we saw in our program was when COVID hit and telehealth was allowed, we were just monthly doing telehealth after telehealth, not seeing our people. A good portion of our people returned to using, and we didn't even know. And when it was time to start coming back in and seeing them face to face, people were either not coming in or they were lost to care or giving us a hard time.
And that makes it hard. By the way, one of the things that we're going to touch on, and there's a graph to go along with it, is in terms of who gets left behind and who gets hit hard with telehealth or the pandemic itself. It has often been underserved or minority communities. And I don't know what pattern you're seeing, but one of the papers that came out, let me see if I can do a quick screen share here again, if I'm fortunate. Let's see here. I'm going to screen share one more time, if I can do it quickly and elegantly. Somebody's getting a phone call.
That's me. I'm sorry.
That's all right. That's all right. Let me just do share screen. So I'm going to do share screen and look for the moment here that I've got the slides showing the, I hope. Yeah. So you can see my slides now, I think. Yep. Yeah. And basically with these, get this over to the side a little bit. What we saw was something pretty alarming during the pandemic.
Anna Rose, we're not seeing your screen.
Oh, I'm sorry, you're not seeing my screen, okay? Somehow thought you were. Can
There
you
you
now?
go.
There you go.
Got it.
Oh, it needs a double click, not a single click. I'm sorry. So even though it's really obvious to me, it's not really obvious to anybody else. So this here, it's right, this slide, we can do quickly go back to it. Is the one that shows that in our region, and this was published in 2021, so it reflects sort of the first year of that pandemic, that there was a flip in the impact of fentanyl and the pandemic according to ethnicity. So that it had been the case in Philadelphia, if you can look at these curves, that basically up until this time, generally, whites were more impacted overall, but something happened during the pandemic so that red line that you see climbing up there for Black males, basically the pattern inverted, so that during the pandemic, we got this huge spike in overdose rates in the Black population, especially Black men. And I don't know if you feel that you saw that firsthand, but it was just one other piece of bad news going along in this pandemic. I'm going to see if I can unshare now for a moment and just have people comment. People have thoughts on this?
It's sad. You know, I'm not, can I say I'm not shocked? But, you know, that's just a group that seems to get missed a lot.
The short end of the stick here.
Yes,
is
yeah,
basically
yes.
already having a pile of disadvantages. And then with all of these stresses, strains of the pandemic, having increased likelihood of overdose now
Yeah.
put on top of it.
Yeah, I mean, I think they're historically a group of people that don't have a lot of support. And it might be hard for them to get support. It's just very sad.
I think it links into the telehealth thing we were talking about, right?
Well, yeah.
In a way, right? So that there are people who are doing fine with telehealth, and you guys
people
can
who don't.
comment, but I'm thinking that may not be the underserved group, or the group that has more struggles to begin with, or the group that is minority or people, communities of color. Would you like to comment on that, Khalil, Daryl?
Yeah.
Te-
Go ahead.
Telehealth was, I mean, we talked about this before as far as the survey. It worked in some communities, but in the communities that we frequent, that I frequent, you know, and outreach and things of that nature,
Right,
a lot of those guys don't have access to telephones,
right,
right? So
Well-
that's an issue.
for sure.
So that can be part of the reason why you see the spike
Yep,
amongst, you know, African American men.
yeah, could be
You know,
pizza,
and
could be
also too, as African American men and men, we don't ask for help. So
Right.
all of that plays a part. You know what I mean? It definitely does.
And can I say about telehealth as a provider, there's audio, and then there's audio and visual. And I like to see somebody when I'm talking to them. You know what I mean? Instead of just having a voice on the other end of the phone, asking me what they need and everything. I mean, I think telehealth can be done. To me, to have an audio and a visual is better than just a visual, and that wasn't always possible. To me, it was just more personal. If I can talk to somebody and I can see your face, and it's not a perfect. It works for some people, but it's not perfect for everybody.
And I guess one thing it doesn't do is what was referred to as like provide this feeling of connection that comes
Right.
from an in-person group, where you feel like you've got your group that you're coming into and you're connecting with, and you know they're going to be there as part of your
Right.
support. And if that's not there anymore, now you're really sort of out there flying on your own, and that's hard, and that can be dangerous.
Yes.
And one of the things too that the use of telehealth with certain population, why it isn't effective, is that prior to the pandemic, members would come to the clinic and they would come to a place where it's safe, controlled, and quiet. A lot of these members' home environment doesn't allow them to actually use telehealth in a way that'll be therapeutic for them.
Right.
A lot of times they, try to do telehealth while they're on the phones or out in the environment. So, it's effective for people to have a stable house environment to actually do telehealth. But a lot of the members that we serve in the urban communities, their home environment is part of the problem. So they really don't have a safe space to like go somewhere for an hour and a half to actually do group.
Yeah, absolutely.
That's
Absolutely.
definitely a problem. And also Khalil talked about too, a lot of times they don't have the minutes for telehealth. They don't have a lot of times we try to do telehealth with members and their minutes went out. They don't have a phone. The screen is cracked. And I think too, something that we really didn't talk about, but I also think the impact of the gun violence in these communities also is having an impact on people, period. And I think that because of these increased anxiety, the likelihood to use drugs, even more drugs, just increased tremendously during the pandemic. And of course, the gun epidemic that's current in Philadelphia is, to be honest with you, is pointing to see the city experience what it's experiencing.
Yeah, I think that, it's another point, because basically, if you're scared anyway about your health from the pandemic or and now you have the fear of not being able to get across the street or back from the store or off your porch without somebody potentially accidentally or intentionally shooting you, that's a huge source of stress and anxiety. It gotta be. Absolutely, it has to be. One of the things we haven't touched on yet is just the severity of withdrawal that people sometimes talk about with regard to fentanyl, compared to previous opioid surges. And I thought it was worth talking about because I know we have clinical teams here that have probably had some patients complain about this, and basically it has an impact whether you're doing clinical treatment, whether you're doing research. If people are in withdrawal, it's a very tough thing if they're not well covered by their medication. So that kind of leads into the what are people asking for today in treatment and what they're looking toward. One of the things that you mentioned to me as we were talking over the last few weeks is that sometimes people are asking now for methadone more than for antagonist treatment like naltrexone or Suboxone. So could we talk about those two things a little bit with you guys coming at it from your perspective in terms of what patients are saying about the severity of their withdrawal on fentanyl compared to regular heroin, and what it means in terms of their choice of treatments?
I see a lot of patients saying that the fentanyl doesn't last as long as heroin, but the withdrawal symptoms are much more severe and last longer. I had a patient who was using 2 bags of fentanyl nasally, and their last use was 72 hours. They took a quarter of a Suboxone and went into precipitated withdrawal. Another issue that I'm seeing is even if we manage the opiate withdrawal, the xylazine that's also in the substances now also has a withdrawal. And from what I hear, clonidine helps, but actually benzos are more better to manage that withdrawal. A lot of providers aren't comfortable prescribing that in the type of setting that I work in.
I think those are both good comments. Let's take them piece by piece and have other people comment too, Mary. So she's talking about the fact that people are talking about the severity of the withdrawal, and then the complication, or what I had on the list as a new wrinkle, xylazine added in, which of course is not an opioid. So opioid treatments don't touch it in terms of an agonist or partial agonist. And you tried to look somewhere else for a way of blunting that withdrawal, but it makes everything more complicated. Would the panel members like to comment a little bit on severity, what people have been saying about it? Thank you, Mary. That was a good comment. Yep.
I'm going to agree with what Mary says. My patients do seem to, the ones that have used fentanyl, they do tell me that they have to use it more frequently. They withdraw sooner, and like she says, it lasts longer. And I mean, the one thing I know is that everybody fears withdrawal.
Absolutely.
Yeah, but that's the one thing that everybody fears. And you know, and that's why I think it's so hard for them to get help, because as soon as like the fentanyl, since it doesn't last as long and they're having withdrawal, you know, it's like, it's almost easier sometimes, I think, to use again and than to come in and get help. And I think they're afraid that the like Suboxone isn't gonna help. I think one person told me that they thought methadone was better for fentanyl. Mary, have you ever heard that?
And methadone was better than fentanyl?
Yeah, no, better for fentanyl withdrawal. To go on fentanyl as opposed to Suboxone.
Suboxone or
that if you're really feeling it, that like you say, the Suboxone puts somebody into precipitated withdrawal.
I feel it's better, mainly because of that, because you don't have to worry about the precipitated withdrawal or going through a washout period.
Mm-hmm.
Yeah, which is what people for going, just comment, where people who are headed toward naltrexone, basically they have to be completely detoxified and abstinent for several days. And if you're in severe withdrawal, it's hard to do that, even if you've got comfort medications or other things that you can prescribe. So it's a hard, as they used to say in the mountains, a hard road to hoe to get there.
Yeah.
And that's one of the things that people have commented on. I think that Kyle and George are tied up with a patient right now, Kyle Campman and George Woody, who do a lot of work with opioid patients. And they had an anecdote that I thought they might be able to share if they were here, but since they're not, maybe I will, in which they were just commenting on the severity of this fentanyl withdrawal, sort of changing the landscape. Because lo and behold, their treatment research project is to try to help people get through withdrawal and get on to naltrexone. And you're going, didn't you just say that that's really hard? Yeah, it is really hard. And what they were trying to do is they had a patient who was, I guess, very heavy person, 7 to 8 days though since the last use of fentanyl. So you'd think that the fentanyl should be gone from the system, right? And that they could be given their Narcan challenge and taken on to naltrexone. But nope. The very unpleasant surprise is that the person went into precipitated withdrawal, even though it had been over a week since they last used, because they'd been in a controlled inpatient setting. There was no exposure to fentanyl. And their thought about this, and I think other people have had some similar thoughts, is that it may be that because it's so good at being stored in the fat tissues, is that basically you have a leaching out of the fentanyl, and it's still around in small enough amounts, but hey, it's so potent, it doesn't have to be large amounts, right? To set up a situation where they could be thrown into withdrawal. So just it's one other rock on the road to try to get to a recovery with an antagonist treatment if you have to go through withdrawal and get through this with fentanyl. Khalil, Daryl, do you have any comments from your members?
Yeah. One thing that we have noticed is that members that are presenting with fentanyl use that wants methadone, it's harder to get them on an effective dose of methadone.
Mm-hmm.
Because Samson recommend a minimum 30 milligrams initially.
Right.
And also, you can only increase it 5 milligrams to 10 milligrams every 3 to 5 days. This dosing schedule is ineffective for patients using fentanyl, given the higher tolerance. It may take up to a month or more to reach an effective methadone dose in these patients. So what's happening is that someone comes to the clinic, they're using fentanyl, they're trying to get on methadone. By the time we can get them to quote unquote an effective methadone,
Yeah,
we lose them.
they're gone. And so, so right now you're in the middle of the regulations telling you can't safely go any faster, but people are still in withdrawal, and so you're between a rock and a hard place.
Yes,
that's tough.
Yeah.
And you're seeing that not uncommonly. That's happening more often than you.
Common. That's how we losing people. That's common now. It's very hard.
Yeah, so that goes to this fentanyl severity of withdrawal comment that we had on our list of topics that I wanted to touch on, because I think withdrawal is something that opioid users don't want anyway, and it was bad enough before with heroin and the other opioids, but this seems to be more severe and also hanging around a long time. If it's really so easily stored in the body's fat tissues, and we all have fat tissues, even if you're not very heavy, you still are storing things in your fat tissues. So you may have this difficulty in getting past, a Narcan challenge to get onto naltrexone, even if you really want to. And it explains why some people who are trying to take their first dose of buprenorphine naloxone would go into precipitated withdrawal. So it's another bump in this landscape that makes things just that much harder. Khalil, have you seen any of this? With people complaining about withdrawal being more.
I pretty much agree with what everyone has said thus far.
About the fentanyl withdrawal severity. Yeah.
Yes. Yeah. It's. I mean, withdrawal from fentanyl, how it's all a scary sight, right, for those involved.
Are you all noticing any change in what people are asking for them when they come in, or would you say that it really is a pendulum shift, that more and more people at this point are now, have they had enough experience with trying to get on Suboxone, going into precipitated withdrawal, so that now they're up front asking for methadone even when they come in? Has it gone that far yet? The pendulum has shifted back that far?
Yeah, I've seen a trend of people that 2-3 years ago tried to get on Suboxone. Now they come in looking for methadone. We definitely have more methadone patients than Suboxone patients.
At the consortium, right?
Yeah, the consortium.
Right.
Definitely see that.
What about PHMC, Mary and Joan? Do you know what is looking
at
like
our
there?
clinic? We do not do methadone. And so I don't, I mean, I would refer out to methadone, but I think too, sometimes in the population, they're pretty savvy, and people, like how I've said, I know that people don't want to go into withdrawal. And if they've been withdrawing or have experienced some withdrawal symptoms from fentanyl, sometimes I think of now that maybe people are going straight to methadone instead and just even bypassing the Suboxone. I don't know. What do you think, Mary?
I've gotten a couple people who have came to get inducted on Suboxone, and were using fentanyl and asked to be referred to methadone. Not a lot. A lot of our referrals seem to already be on Suboxone.
So, I mean, it's interesting though for the field, because I think that for a long time, people were thinking that, that if we had readily available MAT, that people would come running to Suboxone or running to methadone. What we haven't talked about yet, and it's on our little list, is what has been the unintended impact of having MAT be so readily available, even though it's important to do that from the perspective of preventing an overdose. Obviously, you want somebody inducted onto buprenorphine to protect them. But what happens if it's given without connection to a program? Does it get in the way of people getting a full resource program that's a wraparound with support for recovery? All these efforts are important. It's very important to take the medication where the patients are, and very important to try to prevent overdoses. But what happens if people are given the medication and then see that as the only piece of their recovery? Is there a risk there?
Personally think it does more harm than good because it's so readily and easy to achieve. I believe the recovery part has to be done holistically, not just with the medication. I'm really big on getting to the root of the cause. I mean, people use drugs for a reason. A lot of guys don't use just to be using. There's a reason why. Something happened, maybe some of those adverse childhood experiences that they're trying to escape and never dealing with, being the reason why they continue to use. So until that kind of stuff, and mental health issues, right?
Sure.
Mentally,
Yeah.
they both have to be treated together in order to be successful. You can't treat one without the other. And just giving them the medication, me personally, it keeps them from getting sick, but there's no recovery within that process.
Right. So somehow.
So I'm going to continue to do what I do.
Right. And somehow it sounds like we got to wrap this around so that basically the patients understand that this is one step in their treatment and one step in their recovery, but not the final step, right? Not the be all end all, because then they'll wonder, well, why did I relapse? Why did I have difficulty? I went and I got some medication, but then I went ahead and relapsed, but without really maybe having a full understanding of what the various components of a full out, flat out treatment program can be in terms of the supports, in terms of having individual or group treatment, in terms of having other medications for their co-occurring mental disorders. There's, as we've all said here, a lot of pieces that can go into a full and effective treatment program. And we somehow need to get the message out that this first dose of medication is terrifically important. You certainly want to protect people from overdose so they have a chance to make the right choices and to continue their recovery. But how can you get the message out, and we need to, about the fact that this is just one piece, right? That it's got to be part of a bigger piece, or there may be the unintended effect, and really unintended effect of actually having people take medication very shortly, but then be at the same relapse risk and eventually overdose, and wonder why, because they quote unquote got into treatment, right? So it's a very important message. And I don't know, how is it with your patients, with your members, with your clients? What do you tell them about how the medication fits into the overall piece?
Well, here at the consortium, we do both. We're not going to just prescribe a person medication without giving them treatment, because we know that really it really won't help them get the best treatment outcome.
Right.
So we, that's our philosophy at the consortium. Hope that continue to be our philosophy. And one thing too, I want to talk about too, with making it so easy and ready, available. We're starting to see a lot of people that actually don't even come to treatment. They'll go get a doctor to write them a script for Suboxone and just do Suboxone. So we have to really be careful about that, because starting to see more and more people kind of get outside of treatment and just focus in on the medication, which the medication has a definite purpose and a need, but without treatment, it really don't help the member level of function get to where it could be.
Right. It may not take them in the long run to where they want to be. Right. And there's everything to be said for saving somebody's life, obviously, but the message of all the parts of treatment that are important. How is that going with PHMC, Joan and Mary, in terms of what patients think is treatment, and how do you message to them about the various parts of treatment that could be helpful to them?
So we're on the other side. We're not treatment based. We're a primary care center. We do have an outpatient connected to one of our health centers and a partial hospitalization.
Right.
And it's hard to get people to go to treatment after coming to us and seeing a doctor once a month. And I do try to explain to them that the medication is only 10% of your recovery. The other 90% is therapy. But a lot of patients, they just want to get their medication, work, get a place to live, and they're not dealing with the things that caused them to use in the first place. And a lot of times they return to using other substances and don't see it as a problem because they're no longer using opiates. That's our biggest struggle, is accepting that we are only treating the opiate use disorder.
But it's a very important thing that you're doing, but it's also a very important message that you're trying to give them. So sorry for my throat. But I guess the question is how to get that message processed, because here we are in the middle of a pandemic, in the middle of an epidemic and a pandemic, trying to save people's lives and then having them achieve a more sustained recovery. Sorry, I had gotten rid of my cough for a couple hours. I thought I was in better shape. So it's a challenge. When they come into primary care, Mary, do they say, I don't need anything else, I just need the meds? What do they say?
The majority of them say they don't want to do groups. They don't want to have to go to a clinic every day. They just want to get their script.
Yeah, and I mean, on the one hand, it's great to have something that's accessible and that saves your life and that keeps you stable. I think it's a more nuanced, complex message to say to them, this is an important piece, but this is not the only piece if you want to really have a sustained recovery, and that really is going to be more long-term than just keeping you from overdosing this week or this month. So it's a more nuanced, more complex message. Do you guys have? Yeah, go ahead.
Try not to, like, when it comes to our outpatient program chances, if the participants from there come over and want to switch their Suboxone, we try not to do it if we believe that's going to cause the patient to drop out of outpatient treatment. Right. I have had a couple of people where removing the Suboxone from the outpatient was better from them, and they still went to treatment and got their Suboxone from us, but they felt like stigmatized and like the medication was being held over them, and just removing that piece allowed them to go to their outpatient without dealing with that.
Right. It is complex because we're obviously trying to keep people alive to make the good choices on an ongoing basis, but it is complex. And Daryl and Khalil, you were saying that you think that actually it's impacted the attendance or the engagement, the census at your programs? I mean, obviously the pandemic had its own impact, but the ready access to the medications has, you think, maybe impacted your census?
Oh, absolutely, they have. I mean, if they can go and get the get medicated without the treatment part, and you just heard her speak that that's what they want to do. The majority of them is just go get medicated without the treatment. So I mean, yeah, it definitely has played a part in the numbers.
Yeah, I hear you.
I mean, I don't know.
Yeah. By the way, this was one that was at the top of our list, and I said because we have a few minutes left, I wanted to make sure we just touch on it because it's always curious to people who are not necessarily in the field, but about how people will take the risk of a fentanyl overdose because it seems like such a high risk at this point that whatever you use, it may be there, and it's just an interesting thing in terms of a thought experiment. How is it that people can sort of take that risk? And for people who work though with people in the addiction field, say, well, patients are taking risks all the time. And in the big picture, maybe this doesn't seem like such a big one. But of course, fentanyl's changed the stakes, right? The odds of whether or not if you use, you might not have the tolerance, you might not be able to survive it. What do you see in your patients' thought processes? Do they think about the risk being higher now?
No, I think that I want to just comment. This is why treatment is so important. I think a lot of the members don't care if they die or not.
Mm-hmm.
Their living experience and their level of functioning is such that that's not something that they're concerned about. I would think about that at this point, right?
Yep.
But I think that, and that's why I think treatment is so important. I think that's the missing piece. I understand the benefit of harm reduction and how it was needed, fentanyl, but I think that we need to be very careful of making sure that that members also receive some sort of treatment because they don't, they're when someone is using, their thought process is not what a normal thought process. They don't think, well, if I go use this, I'm gonna die. I don't even care. Matter of fact, if they hear that a certain substance kills someone, they will go seek out that substance.
Yeah, that used to be the case all the time. My first work with substance use disorders was in the methadone clinic at the VA, and you would hear, and this was way before fentanyl, that if someone had something that was really powerful with a lot of overdoses, that people would be beating a path to that dealer's door because they knew it was more potent. And you think, wait a minute, that's a really risky thing to do. And it on the surface of it, you think, well, this person is not calculating risks properly. What's going on here? But what you're just saying is that at that point, the person is not really weighing these risks. They're not making that decision. In the big picture for them at the moment, it doesn't seem as heavy, as likely, or when you say they don't care.
Yeah, I have a patient that tells me, he's on Suboxone, and he tells me it calms the animal in my brain. If I'm not on it, the animal takes over. And that's how I kind of, can I say, rationalize to myself my patients that have relapsed or are using, and they can't process, like, that yes, if I do this, there is a risk of dying. I say to myself, it's the animal in their brain is doing the thinking and the rationalizing. And I think when they're using, that's what takes over, and they just, making a rational decision isn't maybe just not something they can do at that point in time. I don't know.
Well, it feels like, yes, some of the decision-making circuits are a little bit circuited. And by the way, we've had a lot of good comments from the panel, but there may be other people in the audience who want to comment on this and who've studied decision-making and studied these processes. I know, Paul, you studied animal models of decision-making and thinking about it with relevance to substance use disorders. You want to say something about that?
I just think this has been a really good panel. I want to thank you all for sharing. I mean, some of the thoughts that just popped in my mind were, this idea of pushing out, like we're going to push out telehealth, and MAT is being pushed out as the main way to treat addiction. And I just feel like this is going to leave a lot of people behind, just kind of echoing some of those concerns. And that worries me. And it's odd that we don't treat addiction like we would mental health, because, if you go into the mental health system, it's almost like guaranteed that you would be getting some sort of counseling and not just a medication. Like those two go hand in hand. So I just think there needs to be a mindset. It's not just a medical issue. It's not just a mental health issue. It's a combined issue. So I mean, off the top of my head, I don't have a lot more to say than that. And again, it's a really good panel.
Yeah, and I want to say something to you, Paul, too. And this is a thought, because thank you for saying it. And sometimes I wonder if it's because of the population that it's impacting. And if this was something, was impacting maybe Bryn Mawr, where, when you go to Kensington and you see, the harm reduction, but actually you don't see no improvement in the community, would they continue to allow this to go, or will they really try to force what you said, like therapy? Like, we all know that therapy is the root. A lot of the issue is unemployment, trauma. So if you don't address these issues, you're really not addressing the issue. The substance use is just the symptom.
Right.
I just thank you. We say harm reduction. I go down to in Kensington all the time, and I see and I'll never forget. I was down at one time, and I watched this little kid walk down this block, and down the block it had to be at least 8 or 9 people that were actually still getting high and still looking, and I'm saying to myself, what goes to the psyche of that little kid as he goes down that block? And I know that if the people that was using substances had treatment, that we'd be able to address that. I've been in this field since 2007. I know what happens if you bring a person in and give them CBT. You constantly try to redirect their thought process, and we're not seeing that. We're seeing like a rush towards harm reduction, which is needed, but it seems like we're forgetting the big piece, which is counseling. And I just don't know where Philadelphia is going to be at the next 5 to 10 years if this continues. Just to be honest with you.
No, I really appreciate the thoughts, because it's actually that's why we're having this panel, is to go sort of get an idea of where we are in this very tough fentanyl landscape, this opioid crisis, and are there things that we're overlooking or that might be surprising to people who are working in the field or with their patients, or who have friends or family members that have struggled with opioid use disorder. And you folks have made a huge number of good points. One thing I noticed on the list, just for sake of completeness, is that we didn't talk much about the fact that fentanyl overdose is harder to reverse. And that goes back to this, what are people afraid of? And you're not thinking about it right at the moment. But you may have heard from your patients that if they had an overdose, that they've been reversed once or twice or 3 times, and that they almost didn't make it, or that they needed more Narcan than was available. Do you want to comment really quickly on that? Because I know we have a couple of minutes left, and I want to leave room for the audience to say anything else as well. But I realize we skipped over that, and it's something that is probably important from the perspective of, practically speaking, when you're using fentanyl, not knowing what you're getting. I mean, it's basically something that you see on the news all the time, that the one dose of Narcan is often not enough, and that the person re-narcotized, they basically fall back asleep again. They're essentially lapsing back down into respiratory depression, and you need another dose, and you may need another dose. And obviously a lot of research going on to try to find things that are better reversers and longer acting, and that will really stick on those opiate receptors and provide protection. But I just wondered if your participants, your patients, your clients, your members have talked about that any of that occurred to them, was it something that had an impact, or is it, as we were talking before, just one small pebble in this big, rough picture that they're all dealing with?
I have not heard that from any of my patients, but I have heard it just like
In the news,
amongst
right?
friends and people
Right.
who I know who are like EMTs, basically. And
Right,
yeah, that's who I hear the stuff like that from.
right. I just wanted to,
more than one dose, multiple doses, and yeah.
and we want to have Narcan around for everybody to have on hand, but it may not be that the first dose is enough. So it's something that I wanted to mention.
Yeah.
Any other comments on that? Mary, Kalel, Daryl?
No, I don't have anything on that
On
particularly.
the withdrawal, I mean, on reversing, on just the reversing.
No.
One thing that we have heard is that sometimes when people get a reversal, that of course they're coming out of withdrawal right at the moment, and they're not in the mood, of course, to get treatment at that moment.
No.
They're feeling such strong withdrawal symptoms that their first thought is, how do I quickly get back out and get an opioid to actually reduce this withdrawal? So that's tricky, because if you would love to think that when a person has come so close near-death experience, that somehow that would produce a state of mind that's receptive to treatment. But at that very moment, they're not. So usually they're just disoriented and very, very uncomfortable and looking for a way to reduce the discomfort. So in terms of the messages and how we structure first step, next step, for the patients that are coming into the ER and coming into these more acute situations than some of the ones that you're dealing with, how do we get that message across? We don't have Jean Marie Perone, who's doing an ER project at the HUP emergency room, where she's trying to do rapid induction, onto Suboxone in a obviously protection attempt. She's one of the people who had described some of these episodes. And of course, you see them in the literature, you hear them on the news, but I just wondered if you'd seen it. And most of you aren't in the ER setting, so it wouldn't have been something that was been right in your face, but I thought you might have had patients comment on it. I want to shut up for a minute and give people a chance to think a little bit about some of the things that we've touched on. We've pretty much touched on everything that was on our preliminary list, and we've added some on top of it. And anything that you would like in terms of questions from the audience. We basically have quite a few people who are attending. And so if people have questions for our panel before we close down, please feel free. And any of these topics, or if you have a comment on something that's entirely different. We've got a lot of experience here represented folks who are on this panel, if you added up all the years. Well, if nobody has any questions, let me say what Paul said, echo him, that this has been extremely helpful. And I think it's a part of the ongoing conversation in terms of how we help our patients and everybody survive these joint crises, the opioid crisis, the pandemic, and the effects and the unintended effects of their being here at the same time. Thank you all so very much. And we'll see you on the next panel.
Thank you for having me.
Next panel, when's that?
Thank you for having me as well.
Thank you.
Thank you, guys. We really
Thank you,
appreciate it.
guys.
Thank you for having me.
Thank you. We appreciate it.